Good morning. I'm here to introduce Dr. Aziz Nazha, who is going to speak on his abstract today. So this segment is the best of SOHO abstracts. This is the first abstract that we have for discussion. We're very excited about this topic. Dr. Aziz Nazha is a final year fellow at the Cleveland Clinic, and his abstract presentation is Mutational Model to Predict Response to Hypomethylating Agents in Myelodysplastic Syndromes. Welcome, Dr. Nazha.
Thank you very much for having me today.
So it is a very interesting and a new topic in MDS. So why do you think it is important for all of us to know about this?
So that's a great question. As you know, treatment with hypomethylating agents such as azacitidine or decitabine can improve cytopenias and prolong survival in patients with myelodysplastic syndrome. However, approximately 30 to 40% of the patient will respond to treatment, and the majority of the patient take up to 6 cycles to response. So identifying biomarkers that can predict response is clinically essential because it can prevent prolonged exposure to ineffective therapy, can avoid toxicity, and most importantly, can save some cost. So new technologies with the genomic sequencing have identified several recurrent somatic mutations that play an important role in myeloid malignancies and MDS. And some of those mutations are also shown to play an important role in survival. There has been prior attempts to kind of utilize this genomic data to see if it can predict response, but that was on limited subset of patients with a limited genomic profiles. So we ask very important questions. Can we take a large genomic data with a large scale of genomic mutations and build up a model that can predict response to hypomethylating agents, where we can identify patients who respond to therapy from patients who will not respond to therapy before they start the treatment?
Excellent. So I guess we are going beyond what we have conventionally done with cytogenetics and to a much higher molecular definition of the disease status in the biology. So even before we actually plan the treatment, we know who are the ones to respond to the standard agents versus the ones that need to go on clinical studies.
Absolutely, and that was the promise of this study, is to able to surrogate those patients who might have a great response to treatment from patients who have very low chance to respond to treatment, so we save them enrollment on ineffective therapy and again exposure to toxicity and cost.
So tell us, how did you go about this with the respect to the sequencing?
So what we did, we obtained clinical and mutational data from our database at Cleveland Clinic of patients diagnosed with myelodysplastic syndrome or secondary acute myeloid leukemia and treated at our institution between 2000 and 2012. We included only patients who received azacitidine or decitabine for at least 4 cycles of treatment. And we used a panel of 62 gene mutations. Those mutations have been described as the most recurrent somatic mutations and the most relevant mutations in myeloid malignancies and MDS. And then we use a logistic regression model where we add age and IPSS to control for the clinical variables and the most significant mutations to build up the new model. So our patient cohort consisted of 122 patients who received treatment with AZA or decitabine, and the median age for the cohort was 69, and their distribution by IPSS and IPSSR risk category as a typical distribution of MDS patient population. And when we looked at the genomic profile of those responders versus non-responders to overcome some of the limitation of the smaller number of some genes in the patients, we have to combine them into their respective pathways. So what we found that mutations in IDH1, IDH2, and TET2 were more prevalent among responders compared to non-responders. Mutations in STAC2 and RAD21 were these mutations from cohesion pathway also were more common in responders versus non-responders, whereas mutations in ASXL1 were more common in non-responders versus responders. And then what we did, we took those significant mutations and added them to multivariate analysis, including age and IPSS score to control for clinical variables. And the final model actually showed that only mutation in TET2, IDH1, and IDH2, as well as mutation STAC2 and RAD21 were significant for response. And again, ASXL1 were predicted resistant to therapy. So we took the beta coefficient of each of those prognostic factors and built up a model based on that. So for example, if the patient has TIT2 mutation, they get a score of 1. If they have ASXL1 mutation, they get a score of minus 1.5. And if they have a STAC2 or RAT21, they get a score of 2. And based on this model and the score, we're able to predict response. So for example, if the patient has a score of 2 to 3, their chance of response to hypomethylating agent is approximately 85%, whereas if the patient has a score of minus 1.5, their chance of response is approximately 15 to 18%.
This is outstanding. So, and this is data, retrospective data that you've collected,
right.
Correct? And so, how do you think it might be applied? Of course, you need to validate this data. So how are you going about doing that?
So this was kind of a pilot study to see, can we use genomic data to predict response to hypomethylating agents? So our effort now, we have sequenced more patients, so we have larger cohort of the patient. We also obtained an independent cohort from collaborators where they have also genomics data on them. So we have nearly around 500 patients now, where what we're hoping is to rebuild the model in a larger cohort of the patient and also validate it in a completely independent cohort, so hopefully it can be applied in the clinic in the future.
Excellent. And one final question. So we do have the current prognostic system, which involves cytogenetics, the poor risk and the good risk. How do you think this is going to be incorporated into the future prognostication schemes for MDS?
So for the prognostication, we already applied the genomic data to IPSSR, and we added the molecular data to IPSSR. What we build now is the IPSSR molecular, and hopefully we'll be presenting it at the ASH upcoming meeting. For the response, we try to control for the clinical variable, but the clinical variable in the IPSS system is fell off the model. So when we get the larger number of the patient, we're gonna look either to control by the IPSS or IPSSR, or just put the clinical variable as kind of a different cutoff, or include them in the model and see if they stay in the model or kind of get out of the model. So we have to see.
Very good. Outstanding. Thank you very much for your time and all the best on your research.
Thank you very much. I really appreciate the opportunity.
Thank you.
Thank you.